Welcome to another episode from Optic Surgeon, the ophthalmology podcast. Today we're diving into the impact of trauma on vision, specifically post-traumatic loss of vision. We've got some detailed information here, and our goal is really to unpack what happens to the eyes, the visual pathways, when they get significantly injured. And importantly, what this means for you in understanding this pretty complex area.
Definitely. We're looking at a whole range of injuries, from direct hits to the eye itself, right up to head trauma that affects the optic nerve, even the brain. We'll also touch on, the immediate signs and maybe some of the longer-term consequences. So maybe start with direct injuries to the eye itself.
Sounds good. Our material covers several ways the eye can be directly damaged, leading to vision loss. One of the really serious ones is a ruptured globe or a penetrating injury. The key seems to be that the eye's actual structure is compromised.
Precisely. Yeah, when the wall of the eye is broken, the absolute first priority is protecting whatever is left and stopping infection. So initial care is all about preventing any more damage.
Okay. Then there are corneal lacerations. So the cornea, that clear front window, a cut there, obviously, that can blur your vision. It sounds like how deep it is and way it is really matters.
Absolutely. I mean, a small scratch might just be uncomfortable for a bit, but a deeper cut, especially near the center, can really mess with your focus. And it can even delay other orbital repairs if needed. Assessing the depth is critical right away.
What about when something actually gets inside the eye, an intraocular foreign body? That sounds particularly nasty for sight.
Oh, it is. Yeah. Depending on what it is and where it lands, it can cause, well, a lot of damage. Scratching the retina, maybe hitting the optic nerve directly. Doctors will usually get a CT scan to find it.
Yeah.
But what's really interesting and important for you to understand is this balance, removing it versus the risk of causing more damage, especially if it's near something vital.
The sources also bring up traumatic cataracts. Now, most people think cataracts, they think getting older, right? But trauma can cause them too.
Yes, absolutely. A solid hit, a direct blow,
Uh-huh.
can damage the lens inside the eye. It makes it cloudy, opaque, just like an age-related cataract. And that cloudiness blocks light, blurs vision.
Okay. Now, commodio retinae. That sounds like maybe a concussion of the retina? Blunt force causing temporary blurriness?
That's a pretty good way to put it, yeah. It's like the retina gets bruised or jarred from the shock wave. Usually the vision comes back on its own, but it's worth knowing that sometimes a retinal detachment can happen later.
Yeah.
So even if vision seems okay initially, follow-up is definitely needed.
Going a bit deeper, there's traumatic choroidal rupture. The choroid, that's the layer with blood vessels under the retina. What happens if that tears?
Yeah, blunt trauma can tear it. And because it's full of blood vessels, you get bleeding inside the eye. If those tears happen to involve the macula, the central part you need for sharp vision, reading, faces, then long-term vision problems are a real concern.
And finally, for direct injuries, there's chorioretinitis sclerotiria. That's a mouthful. This is from high-speed things passing near the eye but not actually going in.
Correct. It's a bit counterintuitive. The shock wave, the sheer force from something like a pellet whizzing past, can transmit enough energy to damage the choroid and retina behind it. It's a pretty specific injury from a near miss, essentially.
Okay, so those are injuries directly to the eye. But what about injuries to the structures around it? The orbit, how can they affect sight?
Right. Good question. Take an orbital blowout fracture, often from, say, a punch or a ball hitting the eye. It's mainly damage to the bone of the socket. But what's relevant for you is how that bone damage can indirectly cause vision problems.
Like muscle entrapment. You mentioned that, especially in kids, it can cause double vision and maybe other weird symptoms too.
Exactly. If one of the muscles that moves the eye gets trapped in the broken bone, it can't move properly. That leads to double vision. And if it's not fixed fairly quickly, that double vision can become permanent. In kids, it can sometimes trigger this reflex, nausea, slowed heart rate. But importantly, if the globe itself is injured, fixing the fracture usually has to wait.
Then there's traumatic retrobulbar hemorrhage, bleeding behind the eye. That sounds like it could build up pressure fast.
It really can. The orbit, the eye socket, it's a closed space, mostly bone. So bleeding back there quickly increases the pressure, and that pressure can compress the optic nerve. That can lead to what we call traumatic optic neuropathy and potentially vision loss. Key signs you'd look for are the eye bulging forward, what we call proptosis. It feels tight if you gently push on it, and the pressure inside the eye might go up too. Recognizing that quickly is vital, as sometimes urgent steps are needed to release that pressure, maybe even a small surgical procedure.
And it's worth noting, blood thinners can make the situation worse, can't they?
Yes, that's highlighted. Anticoagulants, antiplatelets. They can definitely worsen the bleeding, so that's a factor doctors need to consider immediately.
Okay, so we've got direct eye hits, orbital issues. Now, what about head trauma itself? How does that connect to vision loss? Traumatic optic neuropathy, TON, seems like a big one here.
It is. It's critical.
Mm.
TON can happen from direct injury to the nerve, maybe from a fracture fragment, or indirectly from the forces of the head injury itself. What's important for you to grasp is maybe the difference between anterior posterior TON, basically where along the nerve the damage occurs. Direct damage might be, compression, a cut, or even tearing.
And the indirect type is more about those sudden deceleration forces, like in a car crash, causing stretching or shearing where the nerve goes through that bony canal.
Exactly that, yeah. Those forces can disrupt the nerve fibers or their blood supply without a direct blow right there.
There's also Purtscher retinopathy. That's linked to trauma, but not necessarily direct eye or head trauma.
That's right. It's less common, thankfully. Yeah. But you see it after major compression injuries, could be the chest, head, even long bone fractures. What happens is a sudden vision loss, and when you look inside the eye, you see these characteristic white patches, cotton wool spots, and maybe some small bleeds around the optic nerve. Usually it's in both eyes, but it can be asymmetric or even just one eye sometimes.
And shaken baby syndrome. That terribly sad example, but it shows how systemic trauma causes severe eye damage, those widespread retinal hemorrhages.
A critical example. The violent shaking causes extensive bleeding throughout the retina, often right out to the edges. It's a key finding linking that abusive head trauma to devastating visual consequences in infants.
Lastly, the material mentions CNS disorders, not always trauma, but it reminds us vision loss isn't just about the eye, it can originate in the brain, like the occipital lobe.
Absolutely. While trauma is our focus today, it's crucial to remember the whole pathway. Damage to the brain's visual processing centers, for whatever reason, will impact sight. It completes the picture.
Okay, so given this whole spectrum of potential injuries, what are the first steps? What's the approach when someone presents with potential post-traumatic vision loss?
Well, first things first, you need a good history. Understanding how it happened is key. What was the object? How fast was it going? Any other injuries? These details give really important clues. And remember, kids might not be able to give you a clear story, so you have to piece it together.
Then, the examination itself. What are the absolute must checks?
A thorough eye exam. You're checking pupil reactions very carefully, looking for an REPD, a relative afferent pupillary defect, which points towards optic nerve issues. Measuring the intraocular pressure, the IOP, is vital, especially if you suspect bleeding or rupture. And then a careful look at the back of the eye, the retina, the optic nerve. Also, you need to meticulously check the sclera, the white part, for any hidden tears or lacerations.
You mentioned the Seidel test earlier. That's specifically for leaks, right?
Yes, exactly. If you suspect the globe might be ruptured, you put a drop of fluorescein dye on the eye. If there's a leak, you'll see the clear fluid from inside washing the dye away like a little stream. Confirms an open globe. And sometimes, depending on the injury, a gentle look at the eye's drainage angle with gonioscopy might be needed.
Imaging seems crucial too, especially for foreign bodies. CT scans are the usual starting point.
In most trauma cases, yes. CT of the orbits and brain is generally the first-line study. It's great for bone detail, finding metal fragments, but it's good for you to know its limitations. CT scans can sometimes miss things like wood or certain types of plastic. So clinical suspicion remains important. MRI might have a role in specific situations, but often not acutely.
And protecting the eye right away, that seems like basic common sense.
Absolutely fundamental. Put a rigid shield over the eye immediately. Not a soft patch if there's any chance of rupture, because pressure is bad. The shield prevents accidental bumps or pressure.
And then things like tetanus shots, antibiotics, those come into play pretty quickly too.
Right. You always check tetanus status with any open wound. And antibiotics, yeah, depending on the injury type and severity, they might be given as drops, pills, or even IV to prevent infection, especially with penetrating injuries or ruptures.
We've covered the immediate aftermath. What about longer term? What are some potential issues that can crop up down the line after eye or head trauma affecting vision?
Well, several things can develop later on. Retinal detachment is a big one. It's a risk after many types of trauma blunt force, penetrating injuries, even after something like commotio retinae or a choroidal rupture. That's why regular follow-up exams are so critical. Catching a detachment early is key for trying to save vision.
And in children, if one eye's vision is badly affected, you can get amblyopia or lazy eye.
Yes, that's a significant concern in kids. If trauma reduces vision in one eye, the brain might start to favor the good eye and essentially turn off the signal from the injured one. This leads to amblyopia if it's not managed, often with patching the stronger eye to force the weaker one to work.
What about neurotrophic keratitis? That sounds like the cornea losing its feeling.
Precisely. Trauma, and sometimes even the surgery to repair trauma, can damage the nerves that supply the cornea. When the cornea loses sensation, it becomes vulnerable. You might not feel a small scratch or foreign body, making it prone to damage, ulcers, and poor healing.
And glaucoma. Trauma can lead to that too, either soon after or much later.
It can. Secondary glaucoma is definitely a potential complication. It might happen quickly due to bleeding or inflammation clogging the eye's drainage system, or it can develop years later due to structural changes caused by the initial injury. So, monitoring eye pressure long-term is important after significant trauma.
Finally, sympathetic ophthalmia. You hear about this, it sounds quite serious inflammation in the good eye after the other one is severely injured.
It is serious, thankfully quite rare. It's a complex autoimmune reaction where, for reasons we don't fully understand, the body starts attacking the healthy eye after severe trauma to the fellow eye, usually penetrating trauma. While it's rare, it underscores the severity of major eye injuries. Prompt management of the injured eye is thought to potentially reduce the risk, but it's a complex issue.
Okay, so let's try to synthesize this. What does this all mean for you, the listener? As you've heard, post-traumatic vision loss is, well, it's complicated. It covers a huge spectrum of injuries, front of the eye, back of the eye, optic nerve, brain. Right after an injury, that careful assessment is just crucial to figure out what's damaged and to get the right protection and treatment started.
And here's where it gets, I think, really interesting. The body's reaction to trauma is so multifaceted, the visual system is no exception. What we've discussed highlights not just that immediate obvious structural damage, but also the potential for delayed problems. It really underlines why ongoing monitoring is so necessary. Understanding those different mechanisms, was it a direct hit? Was it pressure change? Was it a shock wave? Helps you appreciate why the outcomes can vary so much.
So thinking ahead, what does this mean for future exploration? This deep dive, hopefully, gives you a solid baseline understanding of how trauma impacts vision. You might find it really valuable to dig deeper into specific injury types, maybe look at the latest advances in surgery or medical treatments trying to save sight after these injuries. You could also think about exploring rehabilitation, what helps people who have lost vision from trauma, or the ongoing research into things like neuroprotection for the optic nerve after injury. Lots of avenues there.
Absolutely. Thanks for collating all this important information. We really hope this deep dive has provided you, our listeners, with a clearer picture of post-traumatic vision loss.